Good morning, good afternoon, and good evening, everybody. Thank you very much for joining us for this session today on UHC and cancer prevention. This session comes at a really exciting time, as many of you know. This year we'll host the second UN high-level meeting on universal health coverage, which will try and bring together governments to review the commitments made in 2019 and really chart a course to improving care and particularly implementation over the next few years. So before governments start to get into their negotiations, we wanted to bring the cancer community together to have a series of open conversations around what the opportunities and challenges are. And that's what we'll be doing today, focusing particularly on primary prevention. So as with many of UICC's virtual dialogues, the goal of the session today is really to have a conversation with you all to talk a little bit around where we've seen progress in cancer prevention in UHC, what some of the challenges are, but also to learn from some of the great examples that our expert speakers have, but also yourselves. It'd be great to hear from you all about the work that you're doing and the plans that you have. So without much further ado, it's my pleasure to introduce our speakers that we have today. Coming up first is Mr. Maik Dünnbier, who's the Director of Strategy and Advocacy at Movendi International, and Maik will be talking to us a little bit about alcohol control in UHC. Then we've got Rachel Devotsu, who's the Regional Manager for Africa at the McCabe Centre for Law and Cancer, and Rachel's going to be talking on the use of law, and particularly within the field of tobacco control. And then we're going to be coming to Dr. Anita Borges, who's the Vice Chairperson amongst many other roles at the Indian Cancer Society. And Anita is going to be talking to us about sort of public awareness and kind of leveraging public awareness within prevention and early detection. So I just wanted to say, over the course of this discussion, please do raise your hand if you have any questions. You can also type them into the chat function and we'll keep an eye on things. Once we've had a kind of an opening conversation, we'll move into Q&A and then move people into breakout groups. Those breakout groups will be thematic, so you'll be able to select whichever one is most relevant to you. And then we'd encourage you all to consider two questions. The first is around what opportunities and challenges you see within your context. And the second is really around what you'd like to see governments committing to this year, but I'll pop those up on a slide. There's no need to remember them right now. So mindful of the fact that we have some expert speakers on the line, I think I'll probably kick off the conversation, and I think I'll kick it off with you first, Maik, if that's okay. And probably a broad one to begin with. Where are we seeing progress on sort of alcohol control measures in UHC, and sort of a sub question within that around, we know there's a whole range of measures available within the SAFER package. Which ones are we seeing have been particularly successful, and which ones have we maybe seen a bit less progress on?
Thanks, Rosie. Good morning from Stockholm, everyone, and thanks to you, Rosie, and UICC for this invitation. I think these virtual dialogues of UICC, they are fantastic. And so it's a great opportunity for me to join this group, learn from Rachel and Anita and everyone else. And as you have said, Rosie, the questions you are asking, they are challenging in themselves. I think they're really good questions, broad and then a little bit more specific. So let me just take one step back and just say, from an alcohol policy perspective, we consider universal health coverage, in the sense of it's about strengthening health systems, creating resilient health systems, and actually having health systems in our countries that have the capacity to provide care that people need. And so when it comes to alcohol harm is draining these three dimensions of health systems. So it's weakening, undermining the resilience, and it's of course taking away the capacity of our health systems to respond. We have seen this, for example, during the coronavirus crisis, where some governments then responded and reduced alcohol availability to actually increase the capacity of the health system to respond to the coronavirus pandemic. Right now, shout out to UICC. I think you are doing a fantastic job of addressing alcohol and cancer in the social media. And I think I saw a post yesterday that alcohol causes 740,000 cancer cases annually. So just that fact, I think, shows the big burden that alcohol-related harm puts on our health systems. These cancer cases someone needs to deal with, and that's, of course, our health systems. We have people here, I think, from India and Sri Lanka. In Sri Lanka, we know that every 5th hospital bed is occupied by a person with an alcohol-related condition. And in India, I think India spends 1% of GDP on healthcare. And actually, alcohol harm, if you put it all together, costs 1.4% of GDP. So the alcohol costs to Indian society are bigger than what the Indian society invests in healthcare. So that is just overall the massive alcohol burden and the drain on the system. Alcohol in itself, Rosie, when we talk about universal health coverage, we of course have to talk about alcohol use disorder, alcohol dependence. 9% of the global adult population actually have an alcohol use disorder. Less than 50%, or actually less than 40% of these people are receiving any kind of help. And most people of those 9%, they don't receive any help in countries around the world. Low and middle income countries have no capacity whatsoever to provide any kind of treatment to identify people with alcohol use disorder and addiction. That is the situation, the burden of alcohol on the health system, and then just one dimension of alcohol harm where our countries are not responding well. Now you ask where there is progress or where there are positive developments. The Philippines and their alcohol and tobacco tax is a really good example for a country identifying these things that I just talked about and saying, if we raise taxes on alcohol and tobacco, we can provide health coverage for the poorest of our population. So the Philippines is doing this well. Another example is Thailand, with an overall approach to promoting a healthy population. They also have an alcohol and tobacco tax, and they are earmarking it to reinvest in health promotion campaigns. So you can see here, I think, this interaction between UHC, health promotion, community mobilization for healthy ways of life and healthy environments. And interestingly, I also want to mention Botswana. This country receives less attention when it comes to alcohol policy and universal health coverage. They identified that alcohol is directly linked to their HIV/AIDS epidemic many years ago. So they used alcohol taxes to actually reduce the HIV/AIDS epidemic. And the World Health Organization has written about this case study, successful case, where the health taxes helped reduce the HIV epidemic in Botswana. So now I'm talking about health taxes, alcohol taxes in particular. We have really good evidence, and we have these 3 countries that somehow lead the way. But overall, to wrap up my answer, Rosie, I think for alcohol and universal health coverage, it's really about this integrated approach between the population level measures like alcohol taxes and the return on investment being actually reinvested in strengthening the health system, providing treatment, brief interventions for people with alcohol use problems, and making sure, now we are back at, I think, your expertise, that when there are patients with cancer, that they are being informed about alcohol, for example, so that we have these comorbidities better addressed, that physicians in the primary healthcare setting are empowered to talk about alcohol. We see a big gap there. And these investments from alcohol taxes, they can really unlock this potential there. So that's what I would say to get us started here, Rosie.
Fantastic. Thank you so much for sharing that, Maik. And I think some of the figures that you shared are really sobering, without being too much of a dad joke. particularly in terms of 9% of the global population having an alcohol use disorder is phenomenally high. And I think actually, particularly within the cancer community, one thing we've seen from various surveys of different populations is that there is some broad awareness of alcohol control as alcohol as a key cancer risk factor, but actually that level of awareness and linkages, particularly between kind of key cancer sites, I mean, most notably kind of breast cancers, just often isn't there. And I wanted to sort of understand a little bit from you. Alcohol advocates have had a really great track record of working with other communities, I think partly stemming from the fact, that the measures that you're advocating for are much broader than the health system. They're, as you say, centered in relieving some of the burden on the health system, but they're much, much broader. Can you talk us through a little bit around kind of how the alcohol control community has been working to build collaborations outside of health? Because I think it's a challenge that we often see within prevention. So we'd love to hear a bit more from you on that topic.
This is a great question. It's actually a very nice question. I think it's very nice to experience that you guys think we are doing something well. And I actually see some friends here, Karina from Norway, who is probably even better positioned than me to talk about this. So I think, let me just say, fundamental is really the collaboration with the NCDs community. And I think the collaboration between alcohol policy and cancer prevention and control organizations at the global level. So we are really thankful for UICC. I think you have been leading this kind of collaboration now for many years, World Cancer Research Fund International, NCD Alliance, and now also the World Heart Federation. So other of these global NCD diseases and the organizations are coming in. I think that is fundamental, especially in the context of UHC. So, but we can do more and better. I think at the national level, we can facilitate more collaboration between cancer control and prevention organizations, alcohol policy organizations, especially to, I think, empower the healthcare system to address the link between alcohol and cancer. Even in the health context, I think we can do more on collaboration between HIV/AIDS and tuberculosis organizations, for example, and road safety. The alcohol industry is really hijacking the road safety agenda, funding small NGOs, and using the road safety agenda to then infiltrate the policy-making space. So that is, I think, health. And you can see I'm talking about the elements of SDG 3, because part of the answer to your question, Rosie, is we have analyzed the Sustainable Development Goals. We see that alcohol is an obstacle to 14 of 17 of the SDGs. And as everyone knows, health is just one SDG. So now we have actually 13 other SDGs and organizations that deal with these, that are expert organizations that we can collaborate with. So for us, it's important that we don't just use our facts, go to these organizations, poverty reduction, fair trade, environmental sustainability, planetary health, women's rights, child rights, global tax justice. We reach out, but we want to learn the language of these partner organizations. We just don't want to tell them these are the facts. This is how alcohol interferes with your agenda. Now, please help us advocating for alcohol policy. We want to build partnerships. So we want to say, we are with you on women's rights and women's equality. Alcohol policy plays a little part, but we want to support also your solution. So I think it's really about this kind of partnership approach, learning the language, learning the agenda, and then finding win-win approaches, Rosie. So that's what I would say here.
Fantastic. Thank you so much for that, Maik. And I think, yeah, your point around, how do we, what's our common language and also what's our common goal, and is really important. And we're currently here in New York for the interactive stakeholder hearing on universal health coverage. And it's been really fascinating to sit down with people like TB advocates and just to kind of understand, how and where we're pulling in the same direction and how much of a crossover we really have. So thank you so much for that. And thank you also for flagging Karina, who I may come and pick on a little bit later. But I think one of the things, Mike, you were talking about was, you touched a little bit on the use of taxation and pieces like that, and particularly, other languages. So I wanted to come a little bit to Rachel, who's our representative from the McCabe Centre, because I think when we start to engage with some of the use of law around UHC, more generally, it can sometimes feel like a very different language, even though it's our own languages. So Rachel, I mean, would you be able to give us a bit of background on, how have governments and advocates been using law within UHC? And I know in particular you've been doing quite a bit of work on tobacco control. So over to you. We'd love to hear a little bit more about how we can use this other linguistic area, this other approach.
So like Mike, I'll start with my own definition of UHC. And very often when we have the UHC discussions in Kenya, they focus a lot on treatment. And so especially when you're looking at it from an infectious disease perspective, so if you're talking about HIV, AIDS, or malaria, a lot of the interventions are medical. Now, when you're talking about it from prevention, so you're talking about alcohol, you're talking about tobacco, you're talking about unhealthy food, which are risk factors, then very often we get lost in the debate because all of it is excessively medical. And so the definition that I have of UHC is ensuring that all people have got access to promotive, preventative, curative, rehabilitative, and palliative health services. And so treatment is just part of the curative, but before you get to treatment, you've got promotive. And so when you're talking about health awareness creation, and so what are the substances that people can avoid to avoid getting sick? When you're talking about prevention, and at the level of prevention, we're really looking at what Mike was calling the population-wide measures. So some element of promotive is personal things that you do, but at a population level, you're looking at what governments can do to reduce the population's exposure. And so if you're to try and deal with tobacco and alcohol use just by speaking to individuals and telling them either to get willpower or just to change their habits, that doesn't work. And so if you have to doctor the environment that influences their choices, then you get into the policy space. And that's where lawyers like myself and at McCabe Center come in. And I can see Maxime is here from Norwegian Cancer Society. Hi, Maxime. And so that whole function of promotive and preventative health very often gets lost in the UHC debate, including in Kenya, where I come from. And so not only are you interested in that broad spectrum of the understanding of what health means, but it also means that then the health services that give that whole spectrum have to be of sufficient quality to be effective without exposing people to financial hardship. Now, for example, if you talk about from a tobacco control perspective, if you then wanted to put tobacco control into UHC, you'd have to address two issues. So starting with the most obvious on the treatment side, then obviously you're talking about availability of tobacco cessation services, and not just cessation. So cessation is at two levels. One is, of course, the brief counseling that a doctor or another person can give. And then second is the actual medicines. And so, for example, in Kenya, we've just finished a hospital-based study where we're looking at the morbidity and mortality from tobacco use. And so we talked to about 2,000 Kenyan patients suffering from illnesses like cancer, like heart disease, like chronic respiratory diseases like emphysema and bronchitis, and then diabetes and hypertension. And we found that 22% of all these patients were current or former smokers, which means that 22% of all these patients in Kenyan hospitals who suffer from those diseases can be attributed to smoking. Now, some of them were still smoking even in the hospital. So they're in hospital being treated for cancer, being treated for hypertension, being treated for diabetes, but they're not being treated for the problem that got them there in the first place. So they're not getting cessation treatment because the doctor sees them as a cancer patient. And so going back to something that Anita was talking about before everybody else joined the call, about do we treat diseases or do we treat patients? And so again, with these 2,000 patients that we talked to, we found that there were a lot of comorbidities. And so you find somebody who's got cancer, who's also got diabetes, and who's also a smoker, which means that the doctor that has to treat this person is not treating cancer. Cancer is a condition. You're treating a patient. And that patient is a human being that has got a whole range of problems that need to be dealt with. And so if they come into the cancer clinic, the oncologist only deals with their cancer without talking to them about their smoking habit, without talking to them about their alcohol habit, because one of the comorbidities was also alcohol use. So we've got people who jointly use tobacco, who use alcohol, and then who now have got one disease, and then they have got another disease, but then they have to go through a health system that segments them. So they show up for the oncology clinic and the oncologist only deals with the cancer. Now, if they want information on smoking, then they're supposed to go to another doctor to give smoking cessation advice. Then they go to yet another doctor to deal with their diabetes. Then they would have to go to yet another point in the hospital to deal with the alcohol use problem. And so even from a UHC perspective, you're going to talk about primary healthcare. How do you avoid this siloing so that doctors at the very basic level, which in Kenya would be a dispensary or a lower level healthcare center, when they meet this person, they don't see them as a disease, they see them as a person who could have various health issues, and we have then built their capacity to be able to address this myriad of health issues. And so if you're going to talk about sustainable tobacco control within UHC, you'll have to talk about two things. So on one hand, you have to talk about resources. And so these resources are partly financial and the rest are the human resource capacity, which means training. And very often when we are negotiating the UHC health package, we are just thinking of the medicines and the other inputs. We never think about the funds for capacity building and training of healthcare workers to be able to dispense this health promotive advice that is necessary. And then when now you move to the population level is where then you come to the policies. And very often we like saying that policies don't cost money. I know I'm one person who likes saying that when trying to encourage governments to adopt them, but there are some costs of implementation. And so it's very easy sometimes to pass the policy, but if we don't put in the money to train enforcement officers to be able to track things like illicit cigarettes and illicit alcohol, to be able to do mass media campaigns, then we find that we have got a law on paper, but that's not really being enforced. And so sometimes as we are talking about this UHC, we forget about that resource component. And so for me, I feel that that's where the law comes in. One, to provide for the cessation service, but then two, to then talk about the policies. And so for tobacco control, you're talking about four. You're talking about raising the taxes that Maik has already talked about. You're talking about bans on smoking in public. You're talking about large graphic health warnings. You're talking about banning sales to minors. You're talking about public education and awareness campaigns. And so any government that is serious about doing tobacco control and doing it in a way that brings down the health burden that is caused by tobacco use must not only look at their cessation facilities and availability, but must also look at the tobacco control policies that they have put in place. And so even as we are working in the cancer space, I'm coming at it from different angles, we need to remember the role of law. So it's not just about treatment packages and what benefits people are getting, but that whole the population-wide population measures, and then now the actual treatment for tobacco and alcohol dependence, for example.
Fantastic. Thank you so much, Rachel. And I think that was a really comprehensive answer. And I really liked your kind of initial point in particular, that when we're talking about UHC, we can often drift just into the treatment and care side of things and maybe not appreciate how much, prevention sits and underpins all of these. And it isn't, as you say, just, a handful of policies. It really cuts across, a lot of the work that we're doing and setting populations up for a strong and healthy life, but also responding to their needs as individuals. You touched a little bit on, the point that, policies do sometimes cost money. And I know one of the things that we've seen quite a bit of progress is around the use of law to raise tobacco taxation and as a key resource for UHC, and Maik touched on that a little bit as well. Can you talk a bit more about kind of the use of law for raising funds for UHC, that kind of catalytic eventment, and what it is we need for that to be successful?
So again, what many people who don't engage in the advocacy space don't think about is that taxes are actually raised by law, and they are raised every year. So every year government reads a budget and then raises the taxes to fund that budget. And a lot of us don't engage in tax advocacy. Sometimes it's seen as being complicated. But even as we come with our wish list of what we want to add on to the benefits package, the first question you're going to be asked is how are we going to afford it? So if you come from lower middle income or middle income country like me, I come from Kenya, that's the very first question the politicians ask you. So they agree with you totally, we need to fund everything. Then the big question comes, where will the money come from? And very often we don't have an answer, yet there is actually an answer. And so some of the countries that have done this well, so going back to my earlier point about funding both cessation plus the policy space. So Maik had already talked about Thailand. And I think Thailand is the best example of how they have done it. So they have a Thai Health Promotion Fund that was established in 2001. And this fund gets its resources from a 2% tax on all tobacco and alcohol sales in the country. Now, the beauty about this is that it's sustainable and it's predictable. So the problem with getting funds for health primarily just from the government budget is that when there's an emergency, your funds can be taken away. So for example, when COVID struck, a lot of NCD programs suffered because their funding was diverted to deal with COVID. In Kenya, when there's a cholera epidemic, all the money is just pulled from all the things that are seen as non-essential. So obviously cessation is seen as not such a big emergency as cholera. And so the funding gets taken away. But once you earmark it, as Maik was mentioning, so for example, in Thailand, with this 2%, it's clearly earmarked for the Health Promotion Fund and it can't be taken away. So the sustainability comes because you can predict how much will enter the fund each year. Governments tend to keep very good records of the taxes that are paid by these industries, and so it's predictable. And so what Thai Health Promotion Fund has done is, on one hand, they have taken care of cessation, so they fund a national quitline, and they have the counselors on the other end. And currently they reach 22,000 smokers each year with their programs, and they have a very high cessation rate of about 33%. Then they also fund mass media campaigns, so television and radio, which can be quite pricey, and which is why many countries don't do them. They have the funding to do that. And they also fund other areas of health promotion, so alcohol, road safety, and so on. And so that whole preventive, promotive is adequately funded in Thailand because of the Health Promotion Fund. When you go to Philippines and Egypt, which Maik also mentioned, they instead have used the alcohol and tobacco taxes to fund the national health insurance. And so even though they are taking it out of the tobacco and alcohol tax, they are putting it into UHC. Kenya equally has done the same. And so Kenya, in our tobacco control law, we have got an earmarked tax. So we have 2% of tobacco industry profits that are put into a tobacco control fund. So ours is currently drafted as going only to fund tobacco control, but there are movements towards making it broader to fund national health insurance. And I think the beauty of making it broader to fund national health insurance is that you reach a larger segment of the population. And so then you get more public support for raising the taxes. And so when the industry likes peddling the myth that, oh, it's just a tax grab, it's a money grab by the government, you want to get broad public support for raising taxes, for banning smoking in public. And so if you can show the public that they'll also get some benefit in terms of getting the medical coverage from these taxes, then you remove one of the key arguments that the tobacco industry uses. And so just, I think, the broad span of countries that have done it. So Thailand, I think, is now higher middle income or high income country. You've got Kenya, that's a lower middle income country. It just shows that any country can do this. And so there really is no excuse. It doesn't matter which country you come from, why your policymakers, one, cannot raise the taxes, and two, cannot then channel some of that money into UHC and into rehabilitation for tobacco and alcohol use.
Wonderful. Thank you so much for that, Rachel. That's fantastic. And Anita, I see that you've raised your hand.
Yes. You know, I've been listening to Maik and Rachel and talking about raising taxes on tobacco and alcohol. I'm not sure in the countries that have been mentioned, whether there is a whole lot of tobacco as well as alcohol. And in my country, particularly smokeless tobacco, as well as, some forms of tobacco, smoked tobacco, which we call BDs, which are not really controlled by government regulations, etc. How would you actually, and it forms a very large proportion of, the alcohol, which is local brews and other things. How do we get them into this whole taxation issue? Because that's where the problem lies in a country like ours. And I was interested that in a place like the Philippines, where, and I assume, I'm not sure, but Rachel, in Nigeria, do you have a lot of local brews? Do you have a lot of, homegrown tobacco products, etc., that you would fall out of this net?
So starting with alcohol in Kenya, we do have a lot of home brews. So we've got three types of, alcohol. You've got the traditional that comes in a bottle. You have got what they call second generation, which still come in a bottle, but have got very high ethanol and other contents and tend to cause very severe damage. So when you hear of people going blind and things like that, a lot of it is that second generation alcohol. And then lastly, you've got the traditional alcohol, part of which has also been corrupted. So by traditional, I mean it was brewed from things like sugarcane or, cereals. And so when made traditionally, it is much safer. So you've got now these adulterated versions in slums where they now add things like ethanol and sometimes even formaldehyde, which is the chemical used to preserve dead bodies, just to give it that extra kick. So the place where the government is struggling is dealing with that third category, which is traditional liquor that has now been jacked up and is causing a lot of damage, and obviously does not come in a bottle. And so even when you're talking about prescribing alcohol content or sizes of bottles or taxes, that's a very hard part of the net to catch. But just because it is hard does not mean that we do not need to do it. And so what Uganda has done is that it has, unlike Kenya that banned traditional alcohol, it said, fine, you can produce it, but you have to put it in a bottle. So if you can Google Waragi, it's W-A-R-A-G-I, it's the traditional Ugandan liquor, and they got the traditional suppliers to put it in a bottle. Once you put it in a bottle, it's possible to talk about health warnings, it's possible to tax it, it's possible to talk about alcohol content. And so it's all about contextualizing global measures to your context. And so very often the guidance that we get from WHO, you have to think about what is the particular problem you have back home and how are you going to contextualize this measure. So coming now directly to your question about BDs, the first thing is political will. And so the tobacco industry is very good at saying that you're harassing the small person. And so the BD sellers, BDs are not being made by big companies, they're being made cottage industries, small households. So when you talk about regulating BDs, why are you harassing small, poor Indian women in their homes? And they use that. But they're not only using that to protect the BD industry, they're also using that to protect themselves, who are large multinationals. So the same way they don't want you to raise taxes on BDs, they also don't want taxes raised on cigarettes. And so in terms of getting the political will to address the issue, it's not saying that you're banning the making of BDs. Do what Uganda did. You can still make waragi, but you have to put it in a bottle. In the case of these BDs, they have to be in a packet. So you counter that thing that you're trying to get rid of all these 1,000 million small cottage industries, they have to formalize. And then you decide at which level you want to enforce. So you go gradually. And what actually tobacco tax says is that if we don't levy the taxes on all products, then people switch. So if the only tobacco products that are taxed are cigarettes, then people will smoke BDs because BDs will be cheaper. Now, if all of them are paying taxes, then you avoid that. It's called substitution. And equally for alcohol, it's the same, that if one brand of alcohol is taxed higher than another, so say you tax whiskey more than you tax beer, people will simply switch from drinking whiskey to drinking beer. And you're trying to avoid that substitution within products. So in terms of whether it works, all the data that has been done on alcohol and tobacco taxes show that it is effective in reducing consumption. So if I go back to Thailand, I think they reduced their tobacco use prevalence from close to 29% they are now hovering between 15 and 20 because of all these policies that they have been doing. So tobacco taxes work, all of these policies work, but they only work if they are done as prescribed. So I'm talking to a lot of medical professionals here. Medicine works if you take the right dosage. Tobacco tax, alcohol policies work if they are done the way they are supposed to be done. So part of the reason why we are failing to see impact is because we are not doing it correctly, not because it doesn't work.
I agree, Rachel, but you talked about vested interests, and it isn't just big tobacco that is the vested interest. There are a lot of politicians themselves who are involved in many of these, whether it's smokeless tobacco or it is alcohol or any of these other things, and that's extraordinarily difficult to root out. So I commend all of this taxation and regulation, etc. But it's the implementation that I find is interfered with by vested interests. But thank you for that perspective. It's really to my mind, that's the way to go.
If I could just respond to the vested interests, where again law comes in handy. So at least for tobacco control, we've got Article 5.3 of the FCTC. And so the Framework Convention on Tobacco Control makes tobacco control unique in that we have agreed that the tobacco industry is not a stakeholder for tobacco control. Their interests are directly opposed to public health interests, and so they are supposed to be kicked out of all forms of policy making. Unfortunately, alcohol doesn't have an Article 5.3. And so when Maik talked about excessive alcohol industry interference in policy making, it's because the language still treats the alcohol industry as a stakeholder. And once you make them a stakeholder in the legal sense of the word, that gives them a seat at the table, and they come to the table to mess everything up. And so if we could get a 5.3 for alcohol to kick the alcohol industry out of the policymaking room, not just as themselves, but also through proxies, what we call front groups. So for tobacco control, we have got 5.3. There are still issues with enforcement and implementation, but at least there's the legal obligation to not have the tobacco industry present, and civil society can hold government accountable. And so what I would encourage Anita, part of it is monitoring, figuring out who the industry is using, what are the arguments they are making, countering them where they can be countered, and shaming, naming and shaming. So any politician who's got tobacco and alcohol links, who's acting as a spokesperson for them, must be shamed in the public, in the media, on social media, at home, everywhere, so that we can get them out of the policymaking space.
Thank you, Rachel. Thank you very much.
Fantastic. Thank you, Rachel. And Maik, I wanted to come to you in case you had any key points, particularly around alcohol. I know it's an area that the Movendi has been working on, both in terms of undue influence, conflicts of interests, but also the broader suite of implementation.
Thank you, Rosie. I think Rachel has really given a fantastic answer. There is nothing to add for me, but I can maybe share a few key messages. So the unrecorded alcohol is really important in many low and middle income countries, just part of the overall alcohol consumption. So it needs to be taken care of. And as Rachel has said, governments have tools to do this. So one thing is important, and that is we want to implement health-oriented alcohol taxes, health-oriented alcohol advertising bans, health-oriented alcohol availability limits. And so we can model for what are the consequences and what are the unintended consequences. And then countries show if you implement a track and tracing system, you can get the unregulated market under control. We also know that the unregulated market actually follows the price of the regulated market. Even the people who sell unregulated alcohol, they don't want to sell it too cheap. So even here, alcohol taxation works. And then on this point that Anita raised, but also I think Ishak in the chat is a really great point. I think framing the benefits of alcohol and tobacco control in terms of universal health coverage or in terms of cancer prevention and control really helps to reframe the whole alcohol policy, tobacco control conversation, shifts it away from private profit interests, even the politicians that might be involved. This is a real problem in India. And it allows to build coalitions and say, we want these health promotion taxes or these best buys, and we want reinvestments in systems, in services, in programs that benefit everyone, like Thailand is doing, Philippines is doing. So that's just an addition to what Rachel already really talked about really well.
Fantastic. Thank you so much for that, Maik. And I think one point that kind of has come out for me is, as you say, if it isn't just a tax raise for the sake of a tax raise, if it's a tax raise to then invest in something that communities benefit from, I think actually that public mobilization and that public engagement is a really critical component. I know you raised it and Rachel raised it as well. And I think it also makes me want to kind of bring in Anita as well a little bit more. I know that the Indian Cancer Society has a really long track record of building public awareness campaigns and really engaging the Indian general public in education, but also improving their understanding and engagement with kind of prevention strategies across the country. Anita, can you give me a sense of, how is it that you've been able to do this, and what have you seen coming out of these awareness campaigns? How have you managed to drive this change?
You're right, Rosie, that the Indian Cancer Society has been around for a very long time. In fact, I think in 2026, I know that in 2026, we will be celebrating the 75th anniversary of the founding of the Indian Cancer Society. And I must say that we are very proud of its achievements over the past 70 odd years. It has been, awareness in cancer screening, etc., has been one of its flagship programs. But it's just a little bit about the Indian Cancer Society. It started and is still running one of the earliest population cancer registry programs in this country. So we provide to the global data as well as our Indian data a population-based cancer registry. It also publishes the only cancer journal in India. It offers there's a unique financial help program for cancer patients through a philanthropic mutual fund initiative. And, Vandana would be able to tell you more about the survivorship initiatives, especially for children, and, the very wonderful after treatment of cancer clinics that are, all over, also rehab and for patients and their families. But because of all of this and its very long track record, it has a special place, I think, as an NGO in the Indian cancer space. It's a very credible NGO, and its motto, as far as the awareness program, is "Raho Cancer Se Do Kadam Aage," which means stay 2 steps ahead of cancer. And all of the initiatives of the Indian Cancer Program, particularly with regard to awareness, is that the Indian Cancer Society should be the go-to place for information on common cancers. What are the issues with common cancers? How do you detect them early? What are the different causes or the various different lifestyles that might contribute to, cancer, and so on and so forth. And we have a special initiative on oral cancer because, as I've just told you, that tobacco-related cancers of the head and neck, and in particularly the use of smokeless tobacco causing oral cancer, is really a huge problem. 40% of cancers in our country are head and neck cancers, taking both men and women together, which is a huge burden that we have. And of course, now lung has been added to this. We didn't see as much lung cancer once upon a time, but now we do. So as far as awareness is concerned, we have a very active program to leverage digital technology, because there was the revolution in this country in the days of Rajiv Gandhi, where there was a spread of phones right to the village level, and today, there is smartphone penetration right to the remotest villages of India, and therefore, with various apps and a lot of information on social media can reach people at very distant levels. This is not anymore an urban kind of phenomenon. And you can use high-profile influencers like sports celebrities, film stars, etc. And of course, this doesn't mean that we only use digital technology is the only way to reach people. There is print media, there's the radio, there's cinema. And in fact, the cinema, as I'm sure you are all very aware of, is very popular in this country. We have not just Bollywood, but we have Tollywood, which is, Telangana. And then we have lots of other film sensations in this country. And also using TV and ads and, all sorts of other things. The Indian Cancer Society also engages events at school. We have the Relay for Life. And as we were discussing a little earlier, and Rachel alluded to that, we have felt that family practitioners, what we call general practitioners in this country, are often don't realize just what kind of role that they can play in the lives of cancer patients, not just, early diagnosis, but things at the end of life like pain management and palliative care, and a lot of symptom relief during the treatment phase of this cancer. They're totally unaware of exactly what kind of role. So it's not just awareness to the public as to what cancer is, what cancer does, how one can prevent it, etc., but also to give messages and involve family practitioners in this care. And I think Rachel mentioned that, this is happening in Kenya as well, and they would like to empower family practitioners, which is what we are trying to do, because once a patient goes to an oncologist, it's the family practitioner who may have to deal with a lot of other problems that the oncologist, the patient cannot reach or expect that the oncologist will deal with. The other thing is capacity building, for frontline healthcare workers. Now, India has what is called the Ayushman Bharat program, and I think Maik referred to the very minuscule amount of money in terms of percentage of the GDP that India commits to its healthcare program. But we do have the Ayushman Bharat. But obviously, it is just like in almost any universal health coverage program, a lot of the funds that are located for this, sort of allocated for this program, end up being used for treatment. And there is very little left for prevention, for screening, for awareness, and so many of these other programs, which are really very important if in the end we have to lower the burden of cancer, which we see in this all over the world, because it's now one of the fastest growing non-communicable diseases. And this is where I think the Indian Cancer Society has decided to spend a lot of its clout, and that is to work with governments and also with other NGOs to build capacity for frontline healthcare workers. And we have a program called Satark. Satark is an Indian word for caution, which has been rolled out now across 3 states. This is the first time that the Indian Cancer Society is doing it, in partnership with state governments. And essentially it is to help the state governments who do have funds that are allocated for cancer, but obviously they are extremely meager. So to build capacity with respect to using the existing healthcare workers and the healthcare system to be able to take on this preventive, primary prevention, basically, and awareness task. I think that. Sorry,
Anita. No. This is. My apologies. I wanted to sort of pause you there a little bit, because in the chat we've seen some excellent questions, and And one of them particularly was around, when engaging with the population, and you mentioned the use of digital media and sort of the cinema, and particularly engaging with healthcare providers. One challenge that we've seen come out in the chat is actually around sort of building confidence in new prevention measures. And this person's actually highlighted the HPV vaccine. And I know that this is something that the Indian Cancer Society is starting to work on. So could you give us, there was a beautiful dovetail. So
HPV, no, that's what I was coming to. HPV vaccination is something that is a unique primary prevention measure, which the Indian government is now engaged with. In fact, the Indian government, it's an expensive vaccine, but fortunately we have the Serum Institute of India, and the Serum Institute of India, which did yeoman service during COVID, providing, huge amounts of vaccine, not just for India, but many other parts of the world, has now manufactured a vaccine against HPV, and they are providing it to the government at hugely subsidized rates. And of course, the government will not pass on the cost to in their health coverage program or wherever they are going to launch this. And it has been launched in 6 states of India, and the Indian Cancer Society is active in 3 of these 6 states. So now the question is, as an NGO, how do we contribute to this, the HPV effort in this country? And I think that the space for NGOs over here is to provide accurate information about HPV, its safety, the way that it should be administered, what is actually being prevented. Because, if you talk about other vaccines, it's about preventing infectious disease, illnesses, etc., that the population understands. But now here you are vaccinating young people between the ages of, say, 9 and 14. And what are you preventing? You're trying to prevent something that may or may not happen, when that young person is in their 20s, 30s, or 40s. So it's not a kind of, you're preventing something that is going to happen immediately to an individual. And so this requires, I think, very thoughtful communication to mothers in particular, because this vaccine is being rolled out to girls, and it is being targeted at schools, and the Indian government has asked central and state boards to send out messages to the schools, and through the schools and the children and parents, teacher associations, to the wider community at large. Now, this is a space that I think NGOs and the Indian Cancer Society has taken, a deliberate, or has a deliberate policy to get involved in communication with these, to mothers, particularly women, about cervical cancer, about its prevention in a non-threatening kind of way. Otherwise it might seem like you are, doing something that you're making people take this vaccine when they don't understand exactly why it should be, that it has been rolled out by the government. Of course, the government will have its own initiatives and its own awareness program, but I think we've had a long track record of being able to show good results as far as our awareness program is. And as we speak, there is a debate that is going on around, some small clips that we want to produce to give this message to women in particular. And this is part of an initiative that the Indian Cancer Society has started, not just for HPV, but for cervical cancer screening and control in general. So it fits very neatly into that initiative. And, we hope to roll this out very, very soon, the awareness to people who are Yeah, so we want to complement what the government is actually doing, and that I think is what all NGOs should be about, not to be at odds with government programs, but to, or at some level, be, enablers of, government programs, and also whenever advice is solicited, to give, good advice to government programs. It's a very difficult task. NGOs have to walk a very, very tight line.
Absolutely, and I think that
we cannot be activists. On the other hand, we cannot be complacent. So it's a very fine line, and I think the Indian Cancer Society has got the clout because of its credibility and long years in the field.
History. Fantastic. Thank you so much for that, Anita. I think it's a really wonderful way of wrapping up the session, and I think you make a really valuable series of points around, we are, whenever we're talking about prevention, we are planning for the long run, and we're really investing in the futures of populations, but actually that we need to bring people along with us and help us understand what the benefit is, and move away from, as you say, the scary and the threatening language to really seeing prevention as one of the greatest opportunities we have. And my apologies to everyone on the line. We talked about many of you moving into breakout groups, but given the questions coming through the chat, it felt much nicer to keep us all together in an open conversation. I beg your indulgence. I realise that we are 1 minute over, but I think it falls to me to try and wrap up some of the messages and some of the comments that we've had in the chat. And I think first amongst them is this idea that when we're talking about UHC, we can't forget prevention. It's not universal health treatment. It's actually that full suite of coverage. And that actually, when we're thinking about prevention, how important it is to bring populations along with us, to make it really clear what those benefits are, to build public support behind these interventions, but also as Maik and Rachel kind of touched on, and Anita as well, in terms of the influences in the cinema, we have a whole raft of allies and people who are pursuing a really common objective with us when we look at sort of including prevention in UHC. I think the other thing that's definitely come out is there are so many concrete things that we can push for in UHC, both in terms of the policies we're asking for, and that be better public information, vaccination, key measures that Maik mentioned on alcohol control, but also, as Rachel pointed out, many of these measures in and of themselves provide us with a financial set of resources to really put them into practice. So when we come to our policymakers and they go, absolutely, we'd love to support this, but where's the money coming from? We've got that initial answer to help us continue with the conversation. I think it falls to me to wrap up and say thank you so much to our speakers, Rachel Devotsu, Maik Dünnbier, and Dr. Anita Borges. I wish to thank everyone on the call for joining us, and to encourage you all to participate in the UHC discussions that are taking place this year. It's so important that we see the cancer community and our broad range of colleagues participating in those discussions. And to that end, I'd encourage you all to check out the resources on uicc.org. We'll be providing kind of updates on what's taking place. We'll be trying to signpost you through to resources that you can utilise. For UICC members on the call, we're going to be creating a space in UICC to connect, to just do that, to connect members who are interested in advocacy on UHC. And this is the first in a series that we're going to be doing on UHC and different aspects of cancer control. So do keep an eye out. We'll be having sessions on early detection and diagnosis, treatment, and palliative and supportive care, and we'll be reaching out to you all for those. So thank you all for joining us. Your time is the most valuable resource, and we really appreciate the expertise and there's such an active chat. I hope that you've enjoyed this session, and it just says to me to say thank you all again, and wishing you all the best day you have. And we look forward to continuing the conversation as we move forward. Thank you very much, everyone.